to the highest blood flow.
In order to further illustrate some of the training points from the demonstrations you just witnessed in this segment, we are going to follow Dr. Lurie to an actual pig lab, where many of these life-saving techniques and devices are created and/or perfected.
Shallow, spontaneous gasps. This is a research laboratory, and so we try to control all of the variables so that we can show exactly what we want to demonstrate. And today that is how ineffective conventional CPR is and how we can make it better. If we look in the baseline state before we induce ventricular fibrillation, we can see that oxygen saturation is 99%, the end tidal CO2 is 37%, and on this screen you can see each time a positive pressure ventilation is delivered by the ventilator, the interthoracic pressure, shown here as intertracheal pressure in green, rises and falls. This is the electrocardiogram in red. This panel here shows the brain flow indirectly. We're measuring carotid artery brain flow. This is the blood flow on a beat-to-beat basis. The blue is the aortic pressure. Intracranial pressure is shown in pink, and below in black is right atrial pressure. So we're now going to induce ventricular fibrillation by electrically stimulating the heart with alternating current. You can see that the arterial pressure goes down dramatically as we induce ventricular fibrillation. And you can see that now we are in ventricular fibrillation. The red electrocardiogram is ventricular fibrillation. We will wait for 6 minutes, which is the typical amount of time in American cities that patients have to wait before professional rescuers arrive. 9, 10, 11, 12, 13, 14. With 15 compressions and 2 ventilations, alternating with that compression-ventilation ratio, we can see that the arterial pressure during CPR approximates 60 millimeters of mercury. We can also see that the right atrial pressure in this particular pig is actually higher than the aortic pressure during the compression phase. You can see the small coronary perfusion pressure. That is the difference between the aorta and right atrial pressure. And you can see the blood flow to the brain. During CPR, the blood flow to the brain is only 27 to 30 millimeters of mercury. And then when CPR is stopped, there's no blood flow to the brain. Each time we have to stop compressions, we disrupt coronary perfusion pressure and we disrupt the cerebral perfusion pressure. So you can see it really goes to nothing effectively during each of those pauses. And then we have to regenerate it each time. And each time we regenerate it, it takes time. So one of the major advances, as simple as it is to not give as many ventilations. When we perform CPR with a compression-ventilation ratio of 30 to 2, all by itself, we see a rise in the cerebral perfusion pressure as well as the coronary perfusion pressure. And you can see now that we're giving more compressions per minute. You can see that the carotid blood flow is now up to nearly 40 to 45 milliliters per minute. And the coronary perfusion pressure during CPR is also higher. End tidal CO2 is up a little bit to about 15 to 18 during performance of CPR. When you perform active compression-decompression CPR with a suction cup device on the chest, and you use the impedance threshold device, you generate a tremendous amount of blood flow. It takes a while to prime the pump. So sometimes you need to do this for 10 or 15 minutes because slowly you get blood back into the heart. We now see that the end tidal CO2 is up to 32. Remember, end tidal CO2 is an indirect marker of blood flow. So we've gone from 15 or 17 with a pair of hands. We're at 34 now with the end tidal CO2 and growing. The coronary perfusion pressure is now well over 20. Before it had been about 10. We have now achieved a normal end tidal CO2 of 36. The carotid blood flow is now approaching 50, significantly higher than it was when it was in the teens. You can see what happens each time we compress the chest in pink to the intracranial pressure. Intracranial pressure rises each time you press on the chest, as the pressure in the chest is relayed directly to the pressure in the brain. And you can see that we create a vacuum each time we use this combination of active compression, decompression, and the impedance threshold device. The green shows the vacuum created from 0 to -10. And that small vacuum of -10 millimeters of mercury draws more blood back to the heart. When we perform continuous chest compressions, then you can see you have a continuous coronary perfusion pressure and continuous cerebral perfusion pressure. That's fundamental. Every time you stop compression, everything deteriorates. As you can also see, we can ventilate easily, maintain excellent gases, 98% oxygenation, end-tidal CO2 of 44 with continuous chest compression. We can't overemphasize how important it is to perform continuous chest compressions during advanced life support CPR. That means you've got to rotate frequently because you don't have a device like this to do that. Now that the pig has been successfully resuscitated, we need to figure out how we want to handle the pig hemodynamically. You can see that the pig is beginning to breathe on its own, but in fact we only want to ventilate the pig at 8 to 10 breaths per minute at this point in time. It actually doesn't need more in that department, because more ventilation will result in a higher intrathoracic pressure and it will result in decreased venous return. Let's demonstrate what happens when you ventilate manually at this point in time with 12 breaths per minute and then 20 breaths per minute. When we ventilate, we only want to deliver about 500 to 600 milliliters of oxygen or air with each breath. And you can see each time a positive pressure breath is delivered, there's a rise in the pressure in the chest. You can see with each time we ventilate, we can see a rise in pressure in the airway and in the thorax. Here it's going up to about 40 millimeters of mercury. Ideally, we only want it to go up to about 20 to 30 millimeters of mercury. Each time we give a positive pressure ventilation, look what happens to the pink line here. We see a rise in intracranial pressure. Go ahead and give a breath. A small rise in intracranial pressure. That decreases the cerebral perfusion pressure. One of the common errors after somebody comes back is to hyperventilate them. Let's now hyperventilate them at 30 times a minute. That's not so uncommon. Oh, we can see the blood's flowing up. 30 breaths per minute, the blood pressure is already back down. Oops, daisy, we just killed the pig with hyperventilation. We better do CPR again. We think that oxygen is everything, but we basically killed this pig. And think about all the times we've heard patients thinking we need to give them more oxygen. Each time we add either more compressions per minute, going from 15 to 2 to 30 to 2, or we add the impedance threshold device, or we add the combination of the impedance threshold device and active compression, decompression, we incrementally increase blood flow to the brain, we incrementally increase blood flow to the heart. And as you can see by the end-tidal CO2 rising from 17 up to 40, we incrementally increase circulation.
If you're going to understand cardiac emergencies, you better understand such topics as electrolytes.